morning to all of you. And this is Dr. Praveen Chandra, and along with me is Dr. Siddharth, who are going to share with you this interesting situation. And Dr. Siddharth is going to tell you the history.
So this is a 33-year-old male, known case of diabetes for past 5 years. He is chronic smoker
Adenosine
as well, and patient has a strong family history. His father also had MI at the
FFR.
age of 50. So he had this chest pain 5 days back, which was typical relating to arm associated with diaphyresis. ECG was not revealing any significant STT changes, but his tropi was positive. He underwent coronary angiography, which was revealing main was plaquish, and LAD also had some borderline lesion, and circ was totally occluded, and ramus also has some tight lesion around 70. RCA is also occluded around 100% at the origin. So Dr. Chandra will now tell the treatment strategy
Yeah,
plan for this patient.
yeah. So he has got triple vessel disease, and as you can see on the angio, the right coronary is totally occluded, and the left main has some plaque, but the tight lesion is in the ramus, which is like 90%. And then there is some disease in the LAD, which appears to be borderline at all. So at this stage, we were contemplating that, since looking at his age, he's only 33, that if we just do the two lesions, which is the ramus and the RCA, the circ is not a very big artery. We can leave the circ on medical therapy. And now we were doing the FFR. So we have the FFR wire in the LAD, as you can see here. And I will just check. So you can go to the RFR first. RFR. So the RFR appears to be 9 and a point, no, sorry, 0.85. Yeah. So this is the live RFR. And you can see that this wire, which is in the LAD, and yeah, okay. So this is the situation with the RFR, which appears to be significant. So now I'll do a pullback to see where is the jump. Is it in the left main or is it in the proximal ostial LAD? So here it is. Let us come to a static value, and which is going to be, it is, so once it is static, yeah, it is 0.85, and I'm slowly pulling it back. Okay. So up till now, there is no major jump. Now the jump came here, okay? Now it has become 0.86. Can we check? Okay. So it is very funny that, we don't see any lesion, but we see a jump, and it has become 0.91. Okay. So this is at the site that we find a jump. So the proximal lesions stable as of now, and then there is another jump here, which is 9.96, 0.97. Okay. So let me see where we are. So we are just beyond the left main lesion, and that means the left main lesion is not significant, and we are fine. So we will check on, IVUS also. What is the situation of this? Where exactly is the lesion here? Do we find a true lesion somewhere or not? Show me the IVUS, please. So let us do an IVUS. So this is on the same FFR wire that I'm using the IVUS. Quite okay, largely free of disease in the segment which is beyond this diagonal. And here you have the diagonal and the septals coming in. Again, the disease doesn't appear to be significant. And at this stage, we see some plaque, but again, the MSA looks good to me. And also at this place, now here there is some reduction in the MSA. Where exactly are we? Check, please. Okay, this is just, now we are in the left main. Left main has a plaque, but overall lumen is quite well preserved. So let's review this IVUS, please. So based on this, uh, we will just check how much was the lumen area. It is 4 square millimeters. So the minimum is 4 square millimeters, which is still not bad. And I will see, let us look at this tightest point. Tightest point. So this is the ostium of the left LED. Is that the ostium? Yeah, yeah. Okay. Let's look at this. So there is a disease at the ostium, certainly for sure, around 4 square millimeters. So our cutoff value for very significance here at the ostium of the LED will be about 4.4 to 4.5. So it is just borderline. Okay, so which means that we will see if we have to treat this artery or not. So I'm taking this out. We'll first start with the RCA. RCA will be the first vessel to treat. Show me the RCA. Yeah. So here we have we'll change the guide capture. We'll go with the RCA.
Flush करना इसको.
Yeah. So this is the left which is taken out. And now we'll go with the RCA. This is better. Take a shot, please. A quick shot. Okay. Still, we are not exactly.
Die.
Yeah. Check,
Die
please.
can.
Check.
Yeah.
Yeah, this is better. Okay. So give me a Filter XT. So I'll take a Filter XT for this occluded RCA and see how it goes. And a 1.2 into 6 Filter XT. So the first wire in a occlusion like this, we will prefer to take a soft wire and the coated wire, which is the Filter XT. And in case we find any difficulties, we'll then escalate to Guyot's family of wires. So we have progressed. Let's take a support balloon, 1.2, 1.2, please, because the guiding is having a very, poor support, I must say. So we need some support to this wire. So I'm not sure whether, okay, so can we check in the RO view where we are? Maybe we'll have to go in this direction. It appears that there is a total occlusion somewhere. It is entering into that same branch. Oh, this is RV branch where it is entering into an RV branch. This is another branch, so which means we are in the RCA. This is better. Yeah. Go to RO. RO, please. Okay. Yeah. So this is a branch. So we are trying to enter into a main vessel. This looks like better something. Check, please. Maybe a bigger branch. LO, please. LO. Yeah, it's a big RV branch. Show me the contrast, the retrograde filling injection. The retrograde filling. The retrograde filling is also not very nice, but so the plan is that if you are not able to open this RCA, we might have to still send him for a cabbage. That is why I'm attempting this RCA first. This is a big branch which is entering inside. Can we have a Corsair? So here it looks like we are striking at the occlusion site, because this is a big branch. Yeah, it's a big RV branch. So this is a Gaia 2 now, which I'm going to So now I am doing a parallel wire in this at this stage, and so the strategy will be to find out the main channel with the parallel wire, and in case I'm not able to, then I will think of some other strategy. So it is the first branch which is getting negotiated by this Gaia wire. Now I am into the little bit distal. It's going into another branch, I think. Yeah, this is another branch. So this is another branch or something which I have negotiated. So we'll see in the other view. Aryo, please. Aryo. Hmm. Can we go to the LO? I think we are fine. So we'll take this out, this wire. Okay. And so looks like that we are in the true channel, and that's all right. So this is the Gaia 2 wire which I'm using now, and I'll take a balloon. Give me a balloon, please. Same balloon.
1.28.
1.28. So this is a 1.28. Now we'll look at the balloon passage. Okay. It is crossing. Almost halfway we are done. Maybe a little more. Okay. What? Okay. So the balloon is moving very slowly, inch by inch, and hopefully we'll be able to cross. Okay. But in case we are not able to cross with the balloon, we might resort to a laser. Okay. Okay. We can connect now. Okay. Okay. Go up, please. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Deflate. 10. 10. Deflate. 10. So we'll do serial dilatations. 10, 12. Deflate. 10, 12. Deflate. Okay. No, laser may not be required because we have crossed the balloon. So we will check now. So although this wire appears to be in the true channel, yeah. Okay. So we'll check from the other side. Give me some local, please.
Local.
So I'll do a counter puncture,
5
which I initially avoided, but I will check it.
local. Okay.
No. Echo is good. Echo is good. So let's take a left coronary
JL देना 5 का.
JL. Flush, please. Flush.
JL. JL. 5 की शीत है.
Flush. Flush, please.
Coming. Flush. Flush.
The pressures and everything is okay. I'm just going to take a shot from the contralateral injection. Okay. 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 So go to LAO, little iliocranial. Yeah. Okay. Okay, fine. No, I think we are not. Yeah, it is not in the good branch. So we'll have to abandon it. Not really. So check
Okay.
little. Right balloon inflation at that point. Not really, that much is not required. So we can wait and see. Okay. Yeah. That point. Yeah, proximally. Yeah. Okay. Go up 1, 2, 3, 4, 5, 6, 7, 8. Okay. Keep it on. Yeah, that's fine. 8, 9, 10. That's fine. Okay. So we'll keep it inflated a little bit, but overall everything seems to be okay. So we can abandon this. Yeah. And because in any case he has got the left disease, which is significant, so we'll have to uh, consider everything in totality, despite the fact that we are trying to do this with interventional approach. Echo is good, quite okay. Yeah, no problems. We'll wait for 10 minutes because sometimes there can be a slow fusion. Next. Okay. So we'll wait for 5-10 minutes. And in any case, the LED is also significant. And the ramus is significant, circ is there. So he will be better off with a surgical approach. Perfect. So he's hemodynamically very stable and there is no effusion, nothing. So we're fine. So I think with this we are pretty much done and we stop here. And in this situation, I think it is better, more prudent to plan a second strategy, which is a CABG, because this RCA is not appearing to be that openable, and the left is also diseased. There is a circumflex disease, and also the ramus. So the plan we will change now at this stage, and then accordingly we'll go ahead. Thank you very much. And he's stable. Everything is fine.